The first speaker for today's webinar is Prof. Wong from Faculty of Pharmacy, University Technology Mara, UITM, Malaysia. He will be delivering a talk on the topic Innovative Oral, Inhalational and Skin Drug Delivery for Cancer and Diabetes Treatment. Before the talk, I would like to present a brief introduction of Prof. Wong. Prof. Wong is currently working as a professor in the Department of Pharmaceutics, Faculty of Pharmacy, UITM, Malaysia. He is also serving as a visiting professor for National University of Singapore and Yangzhou University, China. He has obtained his first degree in pharmacy and PhD with the specialization of pharmaceutical technology from National University of Singapore. He has a total of 21 years academic experience and specializes in teaching fundamentals and advanced pharmaceutics and drug delivery systems. His research lies in innovative dosage form design and drug delivery sciences, focusing on oral, pulmonary, and skin medicine for the treatment of cancer and metabolic diseases. Till today, 19 master and 9 PhD candidates have been graduated, and currently 11 PhD and 9 master candidates pursuing their postgraduate studies in his non-destructive biomedical and pharmaceutical research center. Prof. Wong is a founder and co-director of Sino Malaysia Molecular Oncology and Traditional Chinese Medicine Delivery Joint Research Center, Yangzhou University, China. He has published more than 100 publications in high-impact peer-reviewed journals. He is serving as a regional editor for Current Drug Delivery Journal and associate editor for Drug Design, Development and Therapy and Drug Development and Industrial Pharmacy journals. The latest flash news about Prof. Wong is that he is listed in the world's top 2% scientists in the pharmacy and pharmacology. With this brief introduction to Prof. Wong, I am requesting Prof. Wong to start his presentation.
Okay, thank you, Dr. Ravi. Just double check if you can see the slide and hear the voice clearly.
Voice is clear now?
The voice is clear. Can you see the slide?
Yes, slide is okay, yeah.
Slide is okay, okay. Thank you. So first of all, I wish to thank Prof. Shariza from UITM and Prof. Prasad and Prof. Kumar for the kind opportunity to be here for me to share some of the current research finding of our laboratories. So this afternoon, I'm going to share with you on some of the innovative approaches in oral, inhalational, and skin drug delivery for cancer and diabetes treatment. Now, skin drug delivery is one of the primary research area of our center, and we focus a lot on cutaneous melanoma. And you can see in this slide, this is a surface morphology of the cutaneous melanoma. Initially, it initiates in the epidermis. With time, it becomes severe. Sorry, the voice is not so clear. Now, with time, it turns severe and it may actually migrate down to the epidermal junction and sooner or later into the dermis and later on metastasize into the systemic circulation. So various drugs and biologics have been used to treat cutaneous melanoma. Now, for topical local therapies, 5-fluorouracil is recently being found to be able to combat skin melanoma. However, drug deliveries to treat skin melanoma locally are faced with challenges whereby both skin and cellular membrane of the melanoma are the drug's transport barriers. Now, in order to understand how to overcome the skin drug delivery, perhaps let's just take a look at the skin anatomy. Now, principally, the skin is constituted of 3 layers: epidermis, dermis, and subcutaneous tissue. Now, the first layers of the epidermis is known as stratum corneum, Now, it represents the primary drug penetration barriers, whether it's to macromolecular therapeutics or for small molecule drugs. Now, broadly, it's known that the drug transport through the skin is mediated through three routes. First, it can be taken place through simple transport across the epidermis or stratum corneum. Alternatively, the drug can transport across the hair follicles into the dermis and the systemic circulations or through the sweat glands. However, knowing that hair follicle and sweat gland only occupy 0.1% of the total skin areas. So in the case of pharmaceutics and pharmaceutical technologies, we commonly assume that most of the drugs will transport across the epidermis and stratum corneum. Hence, overcoming hurdles introduced by the stratum corneum is the primary steps to take if we want to succeed skin drug delivery. Now, knowing that stratum corneum is such a barrier to skin drug delivery, perhaps you should understand about its anatomical construct. Now, you can see this in this slide, the schematic diagram of the stratum corneum. Now, basically, it consists of corneocyte, which is keratin-rich, embedded in this lipid matrix. If you look closer onto the lipid matrix, you will realize that it's actually made from lipid bilayers alternating with aqueous pores. Now, further look on the lipid bilayer, you will find various lipid compositions such as cholesterol, fatty acid, and ceramide. Now, I wish to highlight to you, despite lipid bilayers is hydrophobic, now it's named as the lipidic compositions, it does contain hydrophilic and polar moiety, such as OH, NH, and carbonyl group associated with the ceramide, right? So transportation of the drugs across the skin primarily mediated through two routes, transcellular and intercellular. Now, a drug molecule needs to penetrate layers after layers of corneocyte if it is to be transported through the transcellular pathway. Now, in the case of intercellular routes, you can imagine that the drugs needs to go through a twist and turn, a very tortuous pathway prior to them reaching the epidermis as well as the dermis. So both transcellular and intercellular drug transportations mechanisms are rather challenging. So it will not be easy to transport the drugs across the skin. So to enable us to successfully deliver drugs, particularly macromolecular drugs, one best way is transiently disturb the systematic structures of the skin, right? So over the past 30 years in pharmacy, we have developed various technologies to overcome skin drug delivery's hurdles. Now, they are broadly classified as passive and active. So the passive technology involves hydration of the skin, whereby applying water to hydrate the skin. The water will enter into the aqueous pore in between the corneocytes. Hence, this will enlarge the aqueous pore size, allowing more drugs to go through. And a lot of skin medicines or even cosmetic and cosmeceutical products, they do contain chemical penetration enhancer, such as oleic acid, ethanol, and surfactant. Now, this penetration enhancer is able to fluidize lipid at the intercellular routes, or they may even extract and get rid of the lipids in order to form a larger aqueous pore for better drug penetration. Now, nanocarrier, of course, is the latest favorite of all scientists. Now, you will note that the nanocarrier, indeed, it can be made from waters, it can be made from oleic acid, ethanol, and surfactants. So with these chemicals, the aqueous pore can turn larger, allow more drugs or even more nanocarriers to go through. Now, of course, nanocarrier has a very unique features in the sense that it is small, it's nano in geometry. Now, it itself can actually squeeze through the intercellular routes and penetrating into the dermis and systemic circulation. Now, what about active technology? Of course, conventionally, we have the 3M adhesive tape to remove the stratum corneum. This is an outdated technique. Microneedle is one of the current hot topics whereby skin is porosified by needles to deliver the drugs. Electrical methods such as iontophoresis, electroporations, ultrasound, sonophoresis, photomechanical wave, and pressurized gas are some of the approaches that have been investigated by various scientists globally. Now, let's take a look on how nanocarrier deliver drugs across the skin. Now, you will see that upon applicating nanocarriers or nanomedicines onto the skin, now the nanocarrier may be released the drug on the surfaces of skin, and the drugs will then diffuse downwards into the epidermis and dermis. Or alternatively, the nanocarrier may be fused with the upper membranes of the stratum corneum, and the drug is released at the upper surface towards the lower surfaces of the skin. Last but not least, of course, the nanocarrier being small and it has a sufficient elasticity, you will be able to squeeze through the intercellular roots and penetrates into the through the intercellular roots into the epidermis and dermis and release drugs at the lower parts of the skin. Now, skin drug delivery by nanocarriers is rather challenging. Now, primarily because the size and the zeta potentials of the nanocarrier will dictate how much drugs can actually go through the skin. Now, in our laboratory, we have conducted a systematic review over, I think, about 200 articles. Now, we realized that the relationship between skin drug transport as well as size of the nanocarrier is not straightforward. Now, we actually examine vesicular carriers such as liposome, attosome, transposome, polymersome, nanoemulsion, and polysaccharide nanoparticles such as alginate nanoparticle, chitosan, and pectin nanoparticles. Now, you realize that unlike what we believe, that smaller size will allow more nano as well as more drugs to go through the skin, but the review outcome shows otherwise. You will see that a lot of small nanoparticles, they actually have a very low skin drug transport propensity, right? And the slightly larger nanoparticle, indeed, they may have a larger skin drug transport propensity. So the relationship between skin drug transport and nanocarrier size is not simple and straightforward. Now, the same applies to zeta potential, surface charges of the nanocarrier. Now, with reference to vesicular carriers such as liposome, attosome, transposome, there's no direct relationship between the skin drug transport versus the zeta potentials of the carrier. Now, in the case of nanoemulsion, we notice that minus 10 to 20 millivolt nanoemulsion is able to transport the drugs better across the skin. Whereas for polysaccharide nanoparticle, we have interesting findings. You will see that positively charged as well as negatively charged nanoparticles are able to convey the drugs or the nanocarriers with a higher propensities to go across the skin. Now, this will not be difficult to imagine. Now, for positively charged nanoparticles, they will be able to attract to the skin layers as the skin is constituted of anionic lipids. So opposite charge attract. So on that note, the nanoparticles, the drugs will be able to deliver across the skin easily. Now, what about negatively charged nanoparticles or nanocarrier? Now, being negatively charged, they are able to repel the anionic lipids of the skin. Now, consequently, the skins will turn deformable, softer. If you can imagine the intercellular roots, the lipids domains may be distorted, thus forming a larger aqueous pore. Now, on this basis, hence the drugs that are released earlier on the surface of the skins may be able to penetrate through the skins easily, or even some of the nanocarrier or nanoparticles may be able to penetrate through the skin because of the deformed lipid matrix at the intercellular root. Now, in year 2000s, our laboratories begins to use microwave, not for skin drug delivery, but for processing of solid medicine, such as microparticles, polymeric bits, tablets, pellets, and granules. Now, what we have found about the microwave is it's able to interact with polysaccharide, protein, and lipid materials of the solid medicine. Now, we note that the microwave can actually enhance the conformational flexibility of polymeric substances. Now, with reference to the skin composition, you note that in the earlier slide, they are made from lipids, a lot of lipids, and also keratins and proteins in the corneal side. So we will wonder, perhaps the microwave can do the same to the skin. Perhaps it can fluidize the lipid zone and hence making larger aqueous pore to allow more drugs and nanocarriers to go through the skin, right? So this is our initial hypothesis. Now further, through our readings, we also realized that microwave has two components, thermal and non-thermal. So in the subsequent investigative study, we wish to capitalize on the non-thermal components and ability of microwave to fluidize, to make the polymeric substances more flexible as an anchor to enlarge the aqueous pore, right? For a better skin drug delivery. So we've carried out a preliminary study. Now in this study, what we have done is we harvest the rat skin and we treat the skin with microwave from the directions of the epidermis. Now you can see that treating the surfaces of the skin with the right frequencies microwave, 2450 megahertz. Now instead of 3985 megahertz, and the right duration, 5 minutes instead of 2.5 minutes, the surfaces of the skin turn smooth, right? Compared to the untreated skin. So this actually alarms us, perhaps the microwave really fluidize certain materials in the skin, and perhaps the systematic structure of the stratum corneum is being destroyed temporarily to allow more drugs to go through the skin. So with all these readings and preliminary studies in mind, we move on to create anti-cancer drugs deliveries through the skin. Now in these studies, we adopt 5-fluorouracils as the drug of interest. This is because the 5-fluorouracil has earlier been reported that they are able to treat the skin melanoma rather effectively at the clinical trials levels. However, note that 5-fluorouracil, though it is small in size, it can actually encounter penetrations hurdles due to its hydrophilic natures, right? So in this study, we formulate the 5-fluorouracils into atosome. And atosome is selected because atosome has been found to be able to improve skin drug retentions relatively better than other nanocarriers such as liposome or even solid nanoparticles, right? So these studies, principally, we wish to deliver 5-FU in the form of atosomes to treat local skin melanoma. So it's meant for topical treatments, not for systemic treatment. So 3 types of atosomes have been formulated. So E5, E10, and E15 represents the atosome with low ethanol content, 5%, and higher ethanol content, 10 and 15%. Now we realize that when the atosomes contain a higher levels of ethanols, it will release the drugs easily, and at the same time, upon application of atosome onto the skin, you realize that a lot of drugs can actually penetrate into the systemic circulations. So this is highly unfavorable because we wish to treat the melanoma topically and locally instead of systemically, right? So E5, among all variants of atosome, is found to be favorable. So you will see that E5 with a lower ethanol content, it does raise the systemic permeations of the drugs, but lesser than that of E10 and E15. But one great advantage of E5 is it actually raised the skin drug retentions. Now in the epidermis or the upper dermis, and this is favorable for local melanoma treatment. Now, an examination of the skin microstructure that are applied with atosomes by FTIR imaging. Now, we realize that the atosomes are able to accumulate in the epidermis when E5 is used compared to E10 and E15. Now, when E10 and E15s are being adopted as the delivery vehicles, perhaps due to the high ethanol content, they are able to penetrate so well through the epidermis and dermis and has been entering into the systemic circulation. Hence, you can't really find it in the epidermis and dermis in a sufficient quantity, unlike E5. Now, E5 is able to be retained in the epidermis, and some of them, you can see the red little dots in the dermis. One possible reason is because E5 is generally larger in size. It has higher levels of negative charges. So with these higher levels of negative charges, this E5 is able to soften the lipid components in the stratum corneum to a greater extent. Now, it may be able to enter into the skin, but it will not be able to go deep down into the deep dermis or the deeper skin layers, and hence disappear into the systemic circulation. Right? And you may wonder that if we want to improve the skin drug retention specifically for topical melanoma treatments, why not we prepare E2.5 or E1 with a lesser content of ethanols? The answer is no, because in the attosome design, we need a minimum level of ethanol in order to keep the attosome elastic, able to squeeze through the intercellular roots. So we keep E5 as the optimal compositions. Now, in order to further retain the drugs as well as attosomes in the epidermis or the upper dermis of the skin, we actually combine the use of attosomes with microwave. Now, we're trying to see what is the outcome if we have a combined treatments on the skin. So you can see that if we treat the skins with microwave at 2450 megahertz for 2.5 minutes, followed by the applications of attosome, there will not be any significant rise in the systemic drug subpermeation. However, the skin drug retention is greatly enhanced when we treat the skin with microwave with the right frequency and the right durations prior to the applications of E5. So this finding is really exciting. And we run against the FTIR imagings to confirm that the attosomes is indeed being located in the epidermis or also in part of the dermis. Now, to enable us to understand why does the use of microwave to treat the skins will enable more drugs and attosome being retained in the skin instead of penetrating into the systemic circulations, we characterize the skin by a few techniques. First and foremost, we characterize the lipid and protein regimes of the skin by means of thermal analysis. We also characterize the epidermis and dermis of the skin that is treated with microwave, with attosome, or with various chemicals of the attosomes by means of FTIR. Now, to make the interpretation simple, instead of going through the values, allow me to use these schematic diagrams to demonstrate to you how the microwave can influence the skin drop penetrations of an attosome. Now, in the earlier slide, I've highlighted that the stratum corneum is constituted of corneocyte and separated by the intercellular roots that is containing of a lipid matrix as well as the aqueous pore. And of course, stratum corneum is part of the epidermis. It is supported by the dermis. Now, treating the skin by microwave will bring several changes to the skin microstructure. First and foremost, the microwave is found through the thermal and FTIR study, is able to actually transform the keratin in the corneocyte from alpha helix to beta sheets. So as a result, the keratins will condense. Now, once the keratins in the corneocyte condense, the larger corneocyte will shrink into the smaller corneocyte. Now, concurrently, the microwave also interact with the lipids in the intercellular roots. So the lipids will be fluidized through mobilizing the hydrocarbons packing. The summative effect is that the intercellular roots of the skins will turn larger right? After treating with microwave, this will then allow drugs and autosomes to go through to penetrate the skin at a greater ease. Now, incidentally, the microwave can also interact with the dermis of the skin. Now, from our study using FTIR and differential scanning calorimetry, now we tentatively conclude that perhaps the microwave can actually interact with the extracellular proteinaceous matter such as elastin, and we suspect that these proteins matters will swell. Now, having a swollen dermal materials, you can imagine that they will form a barrier below the epidermis. So, in conclusion, the drugs and autosome can penetrate well through the skin due to the enlarged aqueous pore, but they will not be able to go deep down, into the lower layers of skin as a result of a formation of a dermal barrier. So overall, there will be more drugs being retained in the skin, and there will be less drugs or less tendency of drugs appearing in the systemic circulation, right? So this is the very first mechanism that has been found by our laboratories, and more works are going to be done, in order to elucidate the more exact mechanism. Now, in order to further verify our in vitro finding, we actually carry out in vivo experiments and using the rat models. Now, the rats, the skin surfaces of the rat is treated with autosome, and in another group of rats is treated with microwave at the right frequency for the right duration, followed by the application of autosome. Now, you will see that the drugs has a less tendency to appear in the systemic circulations when a combination technology is used, and a lot of drugs instead are being kept in the skin layers. So these in vivo findings indeed support the in vitro's outcome, and it also indicates that the combination technology of autosome and microwave can be a potential tool for topical treatments of melanoma. Now, what about melanoma? Now, having succeeding to deliver the drugs across the skin, will the drugs be able to enter into the melanoma and exert its cytotoxic action? But the answer is yes from this slide. Now, you can see that the drug-loaded autosome, as well as the microwave alone, indeed they are able to exert a higher level of cytotoxicity compared to the NEAT drugs, right? And combination use of microwave followed by autosomes bring about synergistic actions against the melanoma growth. And we run the thermal and infrared analysis on the melanoma cell line that is treated with microwave, with autosome, or combinations of autosome and microwave. Now we realize that autosome itself or microwave itself, they can actually fluidize the lipid materials of the membrane, and combination of autosome and microwave will aggressively fluidize the lipid membrane, the lipidic composition of the membrane through interacting with the phosphate moieties available on the melanoma membrane. So this fluidization of the melanoma membrane will allow more autosome and drugs to penetrate into the cellular compartment and exert the cytotoxic action. Now, in the next slide, you will see the confocal electron microscopy data. Now, the cell line that is treated with microwave followed by autosomes appears to have more autosome being migrated into the cellular compartment. And using the same experimental design, we also pre-treated the cell line with various metabolic inhibitors such as cropamazine, nystatin, genistein, and warfarin. Now, we realized that the microwave can actually facilitate the entry of autosome into the melanoma cellular compartment through lipid raft endocytic pathway. So this finding is rather new, and this finding is also corroborate with our skin drug delivery finding, whereby microwave can actually interact with the lipid material of the intercellular roots, right? In order to fluidize them to enable more penetration of drugs across the skin. Now, in another studies, similarly on topical treatments of melanoma, instead of a liquid etosome, we design solid chitosan 5-fluorouracil conjugate nanoparticles. Now, the same findings that is being found. Now, treating the skin with microwave at the right frequency and with the appropriate timings, you can see that more nanoparticle can actually enter into the skin. Hold on. You can't move the slide. All right. Now, the combination use of the nanoparticle, simple chitosan nanoparticle with the microwave bring about synergistic effect to deliver the drugs across the skin for local treatment of melanoma. Now, one of the reasons that we have found out is because the chitosan nanoparticles, possibly due to the chitosan natures, it can actually fluidize the palmitic acid of the lipid domains, whereas the microwave is actually fluidize the ceramide 2 of the skin lipids. So you can see both chitosan nanoparticles and microwave, they fluidize the different lipid composition. So combinations of both efforts will actually synergize their skin drug delivery capacity. Now, in the same study, we further modified the chitosan nanoparticles. Now, in this study, we actually designed chitosan 5-fluorouracil nanoparticles with folate conjugate to it. Now, folate is a targeting ligands for folate receptor that are available on the surfaces of the melanoma membrane. So using chitosan 5-fluorouracil folate conjugate nanoparticle, the same outcome has been derived. You can see that more nanoparticle can be accumulated in the skin layer for treatment of cancer with concurrent use of microwave as a skin penetration enhancer. And the microwave, similarly to the liquid etosome, it actually helps the solid nanoparticles to enter into the cytoplasms of the melanoma through lipid raft endocytic pathway. Right? Now, folate is used in the late study. That's because apart from topical treatments of melanoma, we actually also intend in the future look into the use of chitosan nanoparticle to treat the cancers systemically, right? So folates being targeting ligands to the folate receptor, it play a very important role in order to bring the cytotoxic drugs only to the intended target, that is the melanoma cell. So in one of the recent study, we have found out that 20% folate to conjugate nanoparticles is the ideal composition of folate in order to enhance the intracellular uptake of the nanoparticles into the melanoma cells. Now, with reference to skin drug delivery, now apart from cutaneous melanoma, our recent attempt is to deliver the macromolecular therapeutic insulins through the skin. Now, conventionally, in skin formulations for the purpose of transporting insulin, now oleic acid, linoleic acid, and linolenic acid are used as a chemical permeation enhancer in order to fluidize the skin and enable more drugs or more insulin to go through the skin. Now, in the late studies of ours, we found we have a slightly different findings. Actually, we have found that the fatty acid, be it oleic, linoleic, or linolenic acid, they demote transdermal insulin delivery instead of promote, right? Whereas microwave can actually promote the transdermal insulins to a significantly higher extent than those of fatty acid. Now, this study is really exciting us because this shows that perhaps the combination use of microwave and insulin formulations, you will be able, how should I say, to be transported across the skin now without the need of the fearful injection. Now, what is the reasons why the microwave can improve skin insulin deliveries in comparisons to those of the fatty acid? I think there are two components and two elements that we need to remember. Now, first of all, the microwave can improve the skin permeability. They may be able to shrink the corneal site and to fluidize the lipid layers in the intercellular roots, thus making a larger aqueous pore. This is further illustrated through a transepidermal water loss experiment. So in this experiment, treating the skin with microwave is accompanied by a high level of transepidermal water loss. So the microwave can actually improve the skin permeability. And more importantly, microwave compared to fatty acid, it is a residual-free approach. Unlike fatty acid, which deposit a hydrophobic shield, which is highly unfavorable for skin transport of insulin. Now, to enable us to understand a little bit more about the complication that is brought about by fatty acid, if you look at this diagram, upon treating the stratum corneum with microwave, we have a larger intercellular root favorable for insulin delivery. However, if in any exercise that fatty acids is applied, now this fatty acids is found to be accumulated within the intercellular root, and it forms a hydrophobic shield or hydrophobic barrier. And knowing that insulin is a large molecule drug and it is highly hydrophilic, hence it will be very difficult for the hydrophilic and large molecular weights the insulin to penetrate across the intercellular roots due to the hydrophobic natures of the intercellular root, right? Although the intercellular root has been enlarged, but due to the hydrophobicities, the insulin will not be able to penetrate successfully. Now, let's go to the inhalational drug delivery. So we have recently moved into inhalational drug deliveries, and our experiment is rather simple. We synthesize our own nanomaterials, and following that, we design the nanoparticles, principally decorated with targeting ligands. And in order to deliver the nanoparticles successfully into the lung without being exhaled, and we actually also design microcarrier that can carry the nanoparticles into the deep and peripheral lung. And we hope that in the deep and peripheral lung, the nanoparticle will be released from the microcarrier. And nanoparticle can either act directly onto the cell or being transported into the cytoplasm and exert the cytotoxic action. Right. Now, over the past 10 years, due to the exhalation tendency of the nanoparticles, various researchers have designed various microparticles for inhalation. Principally, we have a nanoagglomerate, nanocomposite, and nanoparticle being encapsulated in the microparticles. Now, all these nanoparticles experience poor redispersibility. Hence, we may not get any nanoparticle in the deep and peripheral lung. And a lot of times, for example, due to the polymeric substances encapsulating the nanoparticles, you may find it the nanoparticle or even the drugs cannot be released for the intended action. And the worst still, in the process of making microparticles, your solvent, your polymeric material may actually distort the nanoparticle size of the nanoparticles. So this is highly unfavorable because uptake of nanoparticle by cancer or even by the normal cells is depending on the size features. Right. So on this note, we actually hypothesize a possible way to deliver the nanoparticles in a better capacity. Now, if you read through the articles for the past 20 years, now the small particles usually is deposit on the coarse microparticles. And this coarse particle will then be inhaled in order to deliver the drugs into the deep and peripheral lung. And note that the coarse particles is having a size of 200 to 300 micron in general. So more often than not, the nanoparticle will not be able to detach from the coarse microparticle. And coarse microparticles being few hundreds micron in size, it will not be able to reach the deep and peripheral lung. Usually is situated at the back of the throat. So when this occurs, there will not be any possibility for the nanoparticle to be inhaled into deep and peripheral lung. As such, we actually hypothesize that we should actually deposit our nanoparticles on a micro scale particle, which is a few micron size. Now let's take the hypothesis that we have derived. Now you can see that nanoparticle alone due to the small size and high specific surface area, they tends to be aggregative. Likewise for micro-scale particle, because it is only a few micron size, they are cohesive and aggregative. So blending of both in a specific weight ratio, you will have the nanoparticles being absorbed on the surfaces of the micro-scale particles. Now note that once the nanoparticle is absorbed onto the surfaces of the micro-scale particles, the aggregativeness of the nanoparticle is reduced. And the nanoparticles sitting on the surfaces of the micro-scale particles, you also can act as a gradient, thus preventing the microparticles aggregating with one another, right? So this system appears to be ideal for simple reasons. Upon aerosolization inhalations, the particles can actually reach the deep and peripheral lung due to the small size in natures. And in the deep and peripheral lung, the nanoparticle can detach from the microscale particles and act on the cancer cells, for example. And even though the nanoparticle is not detaching, but at least the whole assembly of the particle will reach the deep and peripheral lung, right? So on this note, we deem that microscale particle is definitely better than the coarse particle. With this hypothesis in mind, we actually prepare 6 variants of solid chitosan nanoparticle by spray drying. We vary the acetic acid concentration, chitosan grade, molecular weight, chitosan concentration. Also, we use different excipient, twin, span, and ethanol in order to prepare 6 different types of chitosan nanoparticles with different physical-chemical properties. Now, the physical-chemical properties of nanoparticles that are being evaluated are size, zeta potential, polydispersity index, circularity, the shape, the surface roughness, as well as the matrix crystallinity. Now, these properties are evaluated because they are the features that will dictate the nanoparticle inhalation's efficiency. Now, you can see that the nanoparticles prepared are rather round in shape. And we also prepare our own microcarriers. Now, instead of using the commercial lactose inhalations grade, we actually prepare our lactose microcarrier through incorporating polyethylene glycol 3000. Now, this PEG 3000 is very important because it is waxy in nature. It can reduce the hygroscopic nature of the lactose particles. So the lactose PEG 3000 microparticles is only several micron in size. Now you can see the shape is definitely not round, it's a rock shape. And through XRD analysis, you realize that our spray dry lactose PEG 3000 particle is rather crystalline compared to those of the pure spray dry lactose. So this will be good because it reduces the hygroscopicity, which may complicate our inhalation efficiency. Now, blending of the microscale particles as well as the chitosan nanoparticle in a specific rate ratio, we then move forward to conduct a cascade impaction study to simulate the aerosolization and inhalations process of the nanoparticles. And from this exercise, we realized that the size, zeta potential, as well as the circularity of the nanoparticles dictate the inhalation efficiency of the drugs. Now you can see that when the nanoparticles is larger, is rounder, they will have a lower specific surface area. So the nanoparticles will not interact among themselves, but instead the nanoparticles will be absorbed and sit on the surfaces of the microscale particle. Thus, this will enhance their inhalations into the deep and peripheral lung through the help of the microscale particles. And nanoparticle that has a higher zeta potentials, they tend to repel between each others. So there will be a lower level of nanoparticle aggregation. Most of the nanoparticle will absorb on the surfaces of the microscale particles and being brought into the deep and peripheral lung. Now, on the contrary, if the nanoparticle is very small, not circular in shape, they will exhibit a large specific surface area. Now, this nanoparticle tends to aggregate between them instead of absorb onto the microscale particles for transportation into the deep and peripheral lung. So likewise, if the nanoparticle has a lower surface charges, lower zeta potential, they will aggregate between them instead of interacting with the microscale particles for inhalation, right? Now, so far for the solid chitosan nanoparticle, we also actually designed liquid nanoemulsion for inhalational studies. In this study, we actually prepare first, second, and third generations nanoemulsion. The first generation is very simple. Basically, oleic acid, lipid components for us to prepare oil in water nanoemulsion. The second generation, we have a chitosan decorated on the surfaces of the oil droplets. And the third generation, we have chitosan folate, the conjugate, decorated on the surfaces of the oil droplets. Now, chitosan or folate are being used because they are targeting ligands for the macrophage. Now, chitosan can actually recognize the mannose receptor on the surfaces of the macrophage, whereas folate can actually recognize the folate receptor on the surfaces of the macrophage as well as the cancer cells, right? Now, you realize that once we decorate the oil droplets with chitosan folate conjugate, you will see that in the macrophage, a higher level of nanoparticles are being engulfed into the macrophage. Now, as a result, what we can see is that the lung drug content will be higher when we deliver drugs by means of third generation nanoemulsion. So the use of chitosan folate conjugates are able to allow more nanoparticle interacting with the macrophage, and hence more drugs being uptaken by the macrophages, right? So such conjugates, due to the availability of two targeting ligands, we name it as dual receptor targeting. Now, let's move on to the final section on oral drug delivery. Now, in our laboratory, we have been doing drug delivery right from the year 2003. So it has been about 17 to 18 years. Treatment of colorectal cancer by means of oral colon-specific delivery is our main interest in the laboratories. Now, in these studies, we actually create in vivo intracapsular coating instead of fluid-bed or immersion coating. So we have our cancer therapeutic pellets being coated in the body instead of being coated using the machine on the bench top. So let me go through with you on the design briefly. Now, first of all, we actually load the drug into pectin-rich pellets, and we mix the pellets with coating powder, which is constituted of hydrophilic pectin, as well as the hydrophobic ethyl cellulose. So mixing of pellets and coating powders is run in the hard gelatin capsule. Now, upon consuming the hard gelatin capsules into the biological fluid through the gastrointestinal tract, now you realize that in the gastric medium, the coating pectins, due to its hydrophilicity, it will be wetted by the water, so it will turn adhesive, and it will bind the ethyl cellulose to the pellets and form a plug. And this plug is rather resistant to disaggregations along the intestinal transit. Now, however, towards the terminal ileum, the terminal intestinal regions, the plug will begin to disaggregate with time. And in the colon, what happens is that we have a lot of microbial enzymes, and this microbial enzyme can actually digest the pectin of the pellets, as well as pectins from the coating powder mixture. So digestions of the pectins results in disintegrations of the pellets, and the total release of the drugs will occur and takes place in the colonic region. So this study is rather interesting because it adopts a very simple technology, and hence you can actually achieve the same outcome. Now, what interests us more is about the pharmacodynamic performances of intracapsular in vivo coated pellets. Now, these pellets carrying a 5-fluorouracil is able to reduce the size, the number of the colorectal cancer in vivo. It's also able to bring the histopathological grades of the colorectal cancer back to normal. But what interests most is that 5-FU, 5-fluorouracil, that is released from intracapsular coated pellets, in addition to combat the cancer growth, it can actually also reduce the aberrant crypt foci that is found in the colonic region. So this aberrant crypt foci is the preneoplastic lesion. Now, it's the cell population that is about to turn cancerous. So you can see the intracapsular coated pellets is not only just able to kill cancer, it can also kill the precancerous lesion. And this will be very useful for us to totally eradicate the colorectal cancer. Now, in other studies, instead of engaging coating mechanisms, we actually try to formulate pellets that can deliver drugs to the colon without being coated. So we presume that without coating, this will actually save the materials as well as the energies and time of the manufacturers. Now, to cut the story short, now in this study, we actually prepared the matrix using alginate. Now we loaded with ethyl cellulose and calcium phosphate. Now the ethyl cellulose is very important in the initial part of the gastrointestinal transit because due to its hydrophobic nature, it can actually prevent the water ingress into the pellet structure, and hence less drugs will be released in the upper gastrointestinal tract. Now what about calcium phosphate? Now calcium phosphate is water soluble, but it is a moderately water-soluble calcium salt. Now, it will be solubilized only gradually, and this gradual solubilization of calcium phosphate is very important because it will sustain the alginate matrix through formation of calcium alginate structure. And this structure will be rather robust across the gastric and towards and across the intestinal region. And it is only when the whole matrix entering the colon, the structure will be broken down into the smaller particles for site-specific drug release. Now, calcium phosphate is very important. If we use the wrong calcium salt, such as calcium acetate, early disintegrations of the matrix will occur. This is because calcium acetate is highly water-soluble. No doubt, high water solubility of calcium acetate will promote calcium alginate formation, will allow a more robust structure to form. But the fact that fast solubilization will create dispersive forces. So this turbulence and dispersive forces will break the alginate matrix into smaller particles that will render premature drug release. Right? Now, in addition to transdermal insulin, we actually also have an oral insulin project. Now, again, alginate is being used. Now, in this project, we use alginate for multiple purpose. Now, alginates, it has been a long time, known by the ethnopharmacologists that is a sugar absorber. It can interact with the sugar in the gastrointestinal tract and helps to keep the sugar in the intestinal lumen instead of being absorbed into the bloodstream. So alginate, in a way that it does possess some anti-diabetic properties in its own way, right? Now, in the experiment, we also engage alginates as the encapsulating materials for the oral insulin. So we prepare alginate carbon 18 conjugate to encapsulate our oral insulin. Now, alginate alone is not used because alginate can interact with the insulin in an excessive manner to the extent that the insulins cannot be released and it cannot even be detected by the instrument. Through designing alginate in the form of alginate carbon 18 conjugate, this conjugate is able to encapsulate the insulin, protect them, but yet release them when needs to. So alginate carbon 18 conjugate nanoparticles is later being loaded into the calcium alginate bits, which is larger in size, about 1 to 2 millimeter. And you note that the beads materials is alginate. That's because beads material is available in a larger quantum. So using a larger amount of alginates, it can also confer sugar absorbing property that will help us to reduce the rise in blood glucose in the systemic circulation. And the entire nanoparticle in beads is coated with chitosan oleic acid conjugate in order to protect them from early release in the gastric phase. Now you can see that oral consumption in vivo of these structures enable good glucose lowering due to enhanced bioavailability of the insulin in the systemic circulation, right? And looking at the in vitro drug release data, however, we found something unexpected. Now you can see that our coated beads structures is able to reduce the early release in the gastric regions. However, in the intestinal regions, only about 30% of the insulin is being released. But nonetheless, a high bioavailability of insulin is observed in the in vivo study. So the main reason for it is the insulin is being delivered into the systemic circulation, not just by free insulin absorption transmucosally. Now, the insulin is also absorbed through penetrating through the intestinal mucosa and entering the bloodstream thereafter. Now, you can see in this slide, the nanoparticle that we prepare has a very low level of cytotoxicity. It can actually transport across the mucous batters and being trapped by the intestinal mucosa prior entering into the bloodstream to exert the anti-diabetic action. So the uptake of nanoparticles of ours by intestinal mucosa is mediated by cavular and claritrin endocytic pathway. And this will be my last slide, but it's our first very successful attempt to formulate the herbal active into the form of nanoparticles for intestinal targeting in diabetes treatment. So we have been research on Ficus deltoideus for the purpose of anti-diabetic action. Now, through these few years of research, we have identified vitaxins being vital components to lower the blood glucose via its alpha-glucosidase inhibitory action. Now, on this note, we then tries to develop nanoparticles as the carrier for vitaxins and try to deliver vitaxins to the intestinal region specifically in order to interact with the intestinal alpha-glucosidase. Now, how we do it? We have the alginate and stearic acid mixture, and we mix it with vitaxin. We spray dries into the nanoparticles, and subsequently we actually compact the nanoparticles with polyethylene glycol 10,000 into the form of the compact, right? And this compact is being inserted into, it's a very small compact and being inserted into the capsule and administered in vivo for oral anti-diabetic action. Now, what we have found out is that the polyethylene glycol function very well to reduce the vitaxin release to almost 0% in the gastric region. Now, upon compact entering into the intestinal region, you can see a surge in drug release. So the small molecule vitaxin is very hard to control, right? But in our case, we are able to reduce the release in the gastric phase to 0% and enhance the release in the intestinal region. Now, in the intestinal regions, what happened exactly is that the PEG will be eroded with time and in the intestinal fluid. And very importantly, the nanoparticles is constituted of alginate and stearic acid. Now, the alginate is the polyanionic polymers. So in the intestinal fluid, it will experience ionization, losing its proton. It will carry a negative charge and the alginate will repel between each other and the nanoparticles will be dispersed or fragmented. And stearic acid also has its role whereby it will induce wicking. It can actually hit on the nanoparticle matrix and try to disaggregate them in the intestinal region. Hence, more vitaxin will be released in the intestinal region per se for vitaxin targeting on the alpha-glucosidase. Now you can see that if we replace alginate stearic acid with alginate alone, there will be no favorable pharmacodynamic performance. Likewise, now if we replace alginate stearic acid mixture with alginate stearic acid conjugate, the ideal pharmacodynamic actions will not be attained, right? Alginate alone, it will not function very well because there's no wicking action of the stearic acid. And conjugating the stearic acid onto the alginate, you actually restrict the stearic acid movement. So the wicking action of stearic acid is not there. And hence your nanoparticles cannot be dispersed so well in the intestinal regions to release the vitaxin, right? So much so for today. And again, I wish to thank Prof. Shariza, Prof. Prasad, Prof. Kumar from Gitam, my postgraduates, and one of them have become, I think 4 of them have become the lecturers. Dr. Nokaizai Anwar is with us, Dr. Nauman, Dr. Asif, and one Dr. Muham. They are now working as a lecturer in Pakistan and Malaysia. So with that, I thanks again for the organizer for giving me the opportunities to be here, and hope to see you in the future. Thank you.